Hi, this is Neil Hansen, and I am taking you through a multiphasic pancreatic protocol CT scan of the chest, abdomen, and pelvis. These are kind of intimidating studies. They usually have thousands of images. We do a lot of them here. The typical indication for a pancreas CT above just a standard CT is to evaluate for resectability of a pancreatic tumor. There are three main phases that we obtain, although many institutions only obtain two, and that's the arterial and more delayed venous phases. Some people call that early arterial phase the pancreatic phase. It's the phase at which the pancreas enhances most briskly, and so it's ideal to differentiate normal pancreas from tumor on that phase, as well as to evaluate for arterial contact. Additionally, you'll notice up here that we have those 70 keV, 50 keV, and iodine maps typical of a dual energy scan, because many institutions, including our own, do a pancreas protocol CT scan with dual energy to help try and see the pancreatic tumor, which can be very difficult to detect, especially if it's found early. So when I bring up a pancreas CT, the first thing I scroll through is the arterial phase images. So if you bring up these 70 keV images, these are the arterial or early pancreatic phase images. And as you scroll through, you can see that the pancreatic parenchyma is enhancing very brightly, and you can see the subtle lower attenuation tumor, which in this case is in the body of the pancreas. Frequently, you can identify the tumor most easily because the pancreatic duct becomes focally dilated at the tumor head. Most pancreatic cancers are ductal based in terms of their origin, and so the first thing they do is obstruct the pancreatic duct. It makes you better able to try and find especially the tiny ones if you just look for the dilated duct and follow it back to its origin. The 50 keV scan is essentially the same thing as the arterial phase, but again it just makes the iodine pop out. This can be useful to find very subtle tumors. Again, it just accentuates the contrast difference between the pancreatic tumor and the normal pancreatic parenchyma. In reality, if I can easily see the tumor, such as in this case, I do not really even look at this series at all, similar to the iodine map. The iodine map is nice in that it can give you a high contrast image between your pancreatic parenchyma and the tumor, especially if you window aggressively like I just did. However, if the pancreas mass is easy to see, I really don't pay attention to this at all. The virtual unenhanced portion of the dual energy pancreas protocol CT is not really used for much. It doesn't cost the patient anything to get in terms of money or radiation, so we routinely do it, but rarely is it needed. The venous phase of a pancreatic protocol, when done with the chest, is located with the chest CT. So if you're looking for the venous phase as a separate phase, it's best to go to the chest portion and just scroll down. This phase is done during the portal venous phase, so it's done to look for a couple things. One, you get the best liver parenchymal enhancement here, so it's easiest to see small hypodense liver lesions, such as this one in the left lobe. And so when you're looking for the hepatic metastatic disease or doing your metastatic workup, this is the phase that I use. Additionally, it's the phase in which the portal vein and superior mesenteric vein are the brightest. So you'll notice here you've got great opacification of the right, left, and main portal veins so that you can assess for potential tumor contact. Additionally, here's your superior mesenteric vein. The superior mesenteric vein in this case comes within a few millimeters of that pancreatic tumor, and so you can best assess the SMV on this phase as well as the splenic vein. In this case, the splenic vein is actually occluded with all these perisplenic collaterals in the left upper quadrant. The tumor centered right where the splenic vein runs posterior to the pancreas, the tumor occluded that splenic vein. The venous phase is where the pelvis is located, so we scan all the way down into the pelvis. So your workhorse phase for a pancreatic protocol CT scan is the portal venous phase, where you do everything for staging in addition to evaluate for the vasculature involvement of the venous system. Here's a delayed phase. This is obtained a couple minutes after contrast opacification. You can tell it's more delayed because we have some contrast in the medullary pyramids now in the kidneys. This is obtained to look at focal liver lesions. So for example, if you had a hemangioma, it can mimic a metastasis, for example, from a pancreatic neuroendocrine tumor. So it's important to get this delayed phase, because if you see the classic findings of a hemangioma, which is centripetal nodular discontinuous enhancement with wash-in on this delayed phase, then you can be more confident it's a hemangioma and not a neuroendocrine tumor metastasis. I should say that the pancreatic protocol is used for neuroendocrine tumor staging also. Many neuroendocrine tumors are very vascular, so they're easiest to see on these first two phases, the arterial phase or perhaps the 50 keV dual energy CT scan, where iodine really pops out, because the enhancement of those vascular tumors makes them much easier to see on those early arterial phase scans. In terms of reporting pancreas tumors, I'm going to bring up PowerScribe because we have a template here. So if you go to our body divisional templates that you'll be supplied with when starting residency, and you go down to body template pancreas tumor, there are certain things you should mention in every pancreatic tumor assessment report. So I think it's easiest, especially when you're first starting out, to just go in, copy this template, and fill it out. It's important to discuss the location of the pancreatic mass, head, neck, body, or tail, give a maximum dimension, talk about the enhancement relative to the pancreas. Adenocarcinomas are typically hypoenhancing tumors. Neuroendocrine tumors are hyperenhancing tumors, so it can help limit your differential diagnosis. You should always talk about whether the pancreas tumor is confined to the pancreas or not, with a clear fat plane between the pancreas and adjacent structures. Whether the pancreas mass involves the biliary system and causes bile duct dilation, and whether it causes pancreatic ductal dilation. Adenocarcinoma almost always causes pancreatic duct dilation versus neuroendocrine tumors, which more rarely do so. You should discuss whether adenopathy is present and whether the lymph nodes around there are morphologically normal or not, or whether they are enlarged or not. Always comment on metastatic disease, especially most commonly in pancreas tumors within the liver, but also within the lungs or elsewhere. Pancreatic tumors can cause carcinomatosis, so if there's any pancreatic fluid or ascites fluid, it's important to mention it and look to see if there's any nodular enhancement within it to evaluate for possible carcinomatosis tumor spread. In terms of surgical resectability, you should always comment on every case what vessels are involved, and specifically your surgical oncologists are interested in whether the pancreas tumor involves the celiac axis, SMA, SMV, splenic artery and vein, or anything else in the vicinity. Specifically, the hepatic veins are not uncommonly involved. And we use nomenclature in terms of if there is 90 to 180 degrees, we call that abutment. And if there's more than 180 degrees, we call that encasement. So you have to be very specific with your nomenclature, because 90 to 180 degrees of abutment is considered borderline resectable versus 360 degrees of encasement of, for example, the SMA is considered a non-resectable tumor. So it's important to be very specific about these in your reports. You should always comment on aberrant anatomy. Sometimes the hepatic artery arises off of the superior mesenteric artery, or there's other anatomic variants, and that can alter the surgical approach. Similarly, if the tumor doesn't contact the SMV but is close to it within a few millimeters, it's important for the surgeon to know that difference, because occasionally they'll have to do jump grafts of the SMV to facilitate adequate surgical margins. Always comment on the origins of the celiac axis and superior mesenteric artery also, because if there isn't sufficient collateral arterial supply present, occasionally the surgeons can run into trouble if they need to cross clamp one of those arteries to control bleeding. So it's just important to bring it to their attention prior to the potential operation.